And so what we can see from low power here is we have resection of the lung, and we have this unencapsulated lesion, but that is relatively well circumscribed from the adjacent lung parenchyma, which at this low power looks relatively normal. When we zoom into a higher power, we start to see these complex glandular structures forming these central lumina. And then we move to a little bit higher power, we can see that these cells are lined by these columnar cells that have elongated pencillate nuclei. They're fairly atypical with some pleomorphism. They do have some prominent nucleoli. We do see mitotic figures. And the other key feature here is we're starting to see this luminal necrosis within the lumen of these poorly formed glandular structures. This is often referred to as so-called dirty necrosis, and that is a characteristic feature of this tumor. And so right now we would be at an adenocarcinoma. You can also notice the desmoplastic stromal reaction associated with this. And for an adenocarcinoma, it's important to think whether this is a primary tumor or a metastatic tumor. A lot of times the history can help you a great deal. So in this case, the patient had a history of a colorectal carcinoma, as well as bilateral lung masses. And this morphology is very classic for a metastatic colorectal cancer, with this columnar appearance of the cells and this luminal necrosis. However, in some cases, it might be a bit more challenging to differentiate between a primary and a metastatic tumor. It's important to note that this tumor, which has an immunophenotype of cytokeratin 20 positive, CDX2 positive, cytokeratin 7 negative, and TTF1 negative, can be seen in both primary and metastatic tumors. So it's most commonly seen in colorectal cancers, but a subset of primary lung carcinomas can also be positive for CDX2. So none of these markers are completely sensitive or specific. So it is important to correlate with the clinical imaging as well as history. And so in terms of some information around metastasis, so metastases are often the most common pulmonary malignancy we see. If we look at actually an autopsy series, a lung is the third most common site for metastasis after a lymph node and liver. And a common metastasis that we see in the lung include GI, breast, head and neck. And you can also see metastatic sarcomas and melanomas. Classically, at low power, these will be cannonball-like lesions, which are kind of well circumscribed, and that's how you'll see it on gross as well. But in cancer specimens, it's also important to look at the background lung parenchyma. And as we're moving through here, we can start to see some other abnormalities in the lung. And so you'll notice there's these well-formed, non-necrotizing granulomas. And just as a reminder, a granuloma just means a collection of these epithelioid histiocytes with associated lymphocytes around it. And so in these cases, they're relatively poor in the number of lymphocytes. They're mainly these epithelioid histiocytes, and they just have a thin rim of these lymphocytes sprinkled around them. And they're very well-formed granulomas. As you move around, you also see some multinucleated giant cells associated with these granulomas. You can see here some more as well. Many of these do have endogenous calcifications. So these aren't foreign material. This is just endogenous calcifications that can occur in these giant cells. And then the other important thing to notice is the distribution of these granulomas. And so as I'm just going to go to lower power here, you can see them tracking along the interlobular septa here. You can also see them associated with these bronchovascular bundles. We don't have good pleura in this section, but you'd also see them tracking along the pleura. So this combination of involving the bronchovascular bundles, interlobular septa, and subpleura is consistent with a lymphangitic distribution. So putting this together, these features are most consistent with sarcoidosis. However, this is typically a diagnosis of exclusion, and other causes of non of granulomatous inflammation, including infectious such as mycobacterial or fungal, should be considered and excluded. Hypersensitivity and pneumonia typically has more poorly formed granulomas, but may be considered. An important beryllium exposure can cause a very similar appearance to sarcoidosis that is essentially histologically indistinguishable. So it's important to exclude that based on history. So that's our first case. It's a metastatic colorectal carcinoma that shows this infiltration of these complex glandular structures with a desmoplastic stromal reaction. It has this intraluminal necrosis or dirty necrosis of the cells. An important point to remember is that the immunophenotype for this, well, can lead you to think about colorectal cancer. It's not completely specific, as a subset of lung carcinomas can also be positive for CDX2 with a more enteric immunophenotype. And then just highlighting the importance of also looking at the background lung. In this case, there was non-necrotizing granulose inflammation that was consistent with sarcoidosis. So that's our first case.